my presentation is mainly a case-based presentation and show you a lot of examples and hopefully with further
Arun, you are not audible.
Sir, your voice is breaking.
Sorry. The 30-2 field test can show you pick up 98% of neurological field defects. If the visual acuity of the patient is reduced, you can use a larger target, the size 5 target, in patients with reduced field visual acuity. And also, if you have no access to automated perimetry or the vision is very much reduced, you can use the confrontation field. In the usual FRCS exam, they'll show you these two pins, the white pin for checking the peripheral field and the red pin for the central field. So so as automated perimetry is very useful, there's not much use of the Goldman these days. This is the textbook diagram of showing the field defects in lesions in different parts of the visual pathway, and I'll go through these one by one. So as Vijayaraghavan sir had said, we are starting from the optic disc, optic nerve, then the junction, which is junction of the optic nerve with the chiasma, then you have the chiasma, optic tract, lateral geniculate body, optic radiation, and finally the visual cortex. And I'll go through these one by one. So important thing is to try and get a reliable visual field. And once it is reliable, see if only one eye is abnormal or both eyes are abnormal. If one eye is abnormal, then we are looking at a lesion in the anterior visual pathway, that is the retina, the optic disc, or the optic nerve. If both eyes are abnormal and is observing the vertical midline, then it points to either a chiasmal problem or a retrochiasmal problem. If it is not observing vertical midline, it could still be an anterior visual pathway problem, like a macular problem. So that is something you need to keep in mind. If it is affecting both eyes and observing a vertical midline, then, as I said, chiasmal problem will give you what is known as a bitemporal hemianopia, affecting the temporal field in both eyes. But anything behind the chiasma, retrochiasmal pathway, you will get a homonymous hemianopia. The homonymous hemianopia, as it goes along, as Vijayaraghavan sir showed you the different anatomy, as it goes along, there were subtle changes, subtle differences, which will help us to say whether it is in the optic tract, LGB, optic radiation, or optic cortex. So, for example, Vijayaraghavan sir told us that in optic tract lesion, there will be an RAPD. So that gives us a clue. Even though it's a homonymous hemianopia, it tells us if there is an RAPD, it tells us that the lesion is in the optic tract. So I'm going to show you examples now. So first, starting with the optic disc problem or optic nerve, I combine these two together. So the different field defects you can get is a generalized depression, or you can say a central scotoma, because automated perimetry, we're only checking the central field. So it's a central scotoma, and then we can get an altitudinal defect where one upper half or the lower half of the field is affected. In this case, in this example, I've shown you a lower half is affected. That is called an altitudinal field defect. You can get a blind spot enlargement, and I'll show you examples of this. And then you can get what is known as a cecocentral scotoma, a scotoma extending from the blind spot to the point of fixation. So we are going to show you examples one by one. So this is a patient who presented with pain and decreased vision and pain on eye movements of the left eye. You can see there's some inflammation of the optic nerve. And you can see the field test, there's a generalized depression, there's a central scotoma affecting the whole field. So this all points towards the typical optic neuritis. But something quite different. So here you can see the three different patients, and what you can see is what is known as an altitudinal field defect. One half of the field is affected. In this first two cases, the lower half is affected, and the last case, the upper half is affected. So they all point to a problem at the optic optic disc or at the optic nerve, anterior part of the optic nerve. So what you must understand here is the nature of the field effect. If it's an altitude figure, that it means the lesion is in the anterior or either the optic disc or the optic nerve, but it is not going to tell us the nature of the etiology. So these are very different etiologies. This is an anterior ischemic optic neuropathy. This was a traumatic optic neuropathy, while this was a coloboma of the optic disc. So what you must keep in mind, the nature of the field effect will tell you where the lesion is. History, examination, and other imaging will tell you what the lesion is. Moving on, this is a patient present with headache and blurring of vision, and you can see the swelling of the right optic nerve. Left one is absolutely normal. And this patient on the field test has got an enlargement of the blind spot. So this is another field effect you get in optic disc problems. And this is another patient. You can see the decreasing vision in both eyes for 2 months. And this is what is known as a secocentral scotoma. So the scotoma, this is the blind spot is here. And this is the point of fixation. So the scotoma is extending from the blind spot to the point of fixation. This is the left eye, and the same thing, the right eye, from the blind spot to the point of fixation. This is what is known as a secocentral scotoma. It's extending from the blind spot to the central point. And this is typical of nutritional or toxic optic neuropathies, and usually it is a bilateral involvement. In this case, it is due to the alcoholism. So these are the few examples of the different types of field effects you get with lesions of the optic disc and the optic nerve. Now we are moving on to the junction. The junction means the junction of the optic nerve with the chiasma. And in this characteristic, Vijayaraghavan sir, I told you, probably you remember from his talk that he spoke of a Willebrand's knee. So that means the nasal fibers from the, for example, in this case, the left eye, they come to the chiasma. They actually extend a little into the optic nerve on the opposite side, the right side, and then they again go into the optic tract. So what you can see here is that the patient gets a central scotoma in one eye, and the other eye, because of the nasal fibers affected from the other side, the temporal defect in the opposite eye. And this is exactly as in my patient here, completing a decreased vision in the right eye, so you can the central scotoma in one eye and a temporal defect in the other eye. So this is what is known as the junction scotoma. And that points to a lesion, and usually it's a compressive mass lesion at the junction of the optic nerve with the chiasma. And exactly as you can see in the MRI here, that was a lesion at the junction of the right optic nerve with the chiasma. So there is here the most important point to remember is when the patient complaint is in one eye, check the field in both eyes, and that temporal defect in the other eye gave you the important clue. Going on to the chiasma, all of you know this from your entrance exam days. A chiasma lesion, typically a pituitary lesion, causes a bitemporal hemianopia. So this is a nurse with a complaint of history of infertility, and you can see obviously that points to an endocrine problem, and you get what is known as a bitemporal defect, and you can see very nice bitemporal hemianopia, and you can see the large macroadenoma here. And fortunately, she did very well with surgery. You can see the marked improvement in the field after surgery. Moving on. Now, all cases of bitemporal may not be that clear cut. You can see this patient here, field defect, some vague field defect in each eye, right eye, left eye. But important thing is you put it oriented properly. You always hold the field such as the left field on the left side, right field on the right side, just like the patient sees. And then it makes sense. So this is actually again a bitemporal hemianopia. The patient is only the upper half is affected right now, but if you don't treat the condition, then it is going to become a complete temporal hemianopia. So right now only the upper quadrant is affected because the pituitary is compressing the fibers from below. So it is an evolving bitemporal hemianopia. So most important point you must remember here. So her complaints were quite vague. There's some vague decreasing of vision. Vision was 6/6 in both eyes, some color reduction in the left eye. But important point you must here remember is that in all unexplained vision loss, do a visual field. And always hold the visual field as the patient sees. That is left on the left, right on the right. And then it makes sense that this is a evolving bitemporal hemianopia. Going on to the lateral geniculate nucleus. This you can get what is known as a sector anopia because of the peculiar blood supply of the lateral genicular body. It has got an anterior and posterior choroidal arteries. And because of the peculiar blood supply, sometimes you get what is known as a sector anopia, and sometimes you get what is known as a sector sparing homonymous hemianopia. These are not that common. I've only seen 1 or 2 cases in 23 years, but it is something you should keep in mind. Now, going on to optic radiation, Vijayaraghavan sir told us the superior fibers go through the parietal lobe, while the inferior fibers go through the temporal lobe. So then you get what is known as a pie on the floor if the superior fibers are affected, because that is subserving the vision for the inferior retina. So you can see here, you can see both eyes, or left eye, the right inferior quadrant is affected, and right eye also, the right inferior quadrant is affected. So this is what is known as a inferior quadrantenopia, and that points towards a parietal lobe lesion. And again, another one you can see here, the temporal lobe fibers are affected, so you get what is known as a superior quadrantenopia, or pie in the sky. One is called a pie on the floor, other is called a pie in the sky. The last one is coming to the occipital lobe, and here you can see if there's you get a homonymous hemianopia. But if there's sometimes you may be lucky, you can get a sparing of the macula, as you can see in this patient who had a field defect after bypass surgery, and that is because the tip of the occipital lobe, which observes the macula, has got a dual blood supply. And so if you're lucky, that gets spared. And this patient actually had 6/6 vision, but he was saying some visual disturbance. Again, the same rule, if unexplained vision loss, check the fields. And you can see a macular sparing homonymous hemianopia. So just like to summarize the important points you need to remember, always do a field test in an unexplained vision loss. Always hold the field like the patient sees, left on the left, right on the right. Hold the field like the patient sees, as I've shown you in this picture here, and then the diagnosis will be clear to you. As I mentioned, the pattern of the visual field will tell you the location of the lesion, but the history, examination, and imaging will tell you the nature of the lesion. And finally, most important, always correlate clinically. So everything should make sense. Your field test should correspond to your examination findings or imaging findings. Otherwise, you need to look for some other cause. Thank you very much.